Okay, I've just started recording and we're also on Facebook Live. So welcome everybody. So thank you very much for joining us today. We've got two speakers lined up whom we're very happy to have. For those who've not joined us before, the PGSSC Global Surgery Research Seminar is a 10-session series which seeks to explore methods and outcomes of surgery and research. It happens on the first Thursday of the month, and we normally have two speakers who talk about similar topics and methods. This is followed by an open discussion on the results and methods. Where we will be recording the seminar, and the videos will be posted on our website after the seminar. And we also do have a complimentary journal club, which runs on the first Thursday of the month as well. Okay, so I just wanted to thank my team, especially Adeline and Bethany for organizing this. I'd also like to thank all the fellows and RAs who've been working hard to get this seminar off the ground. Our next seminar will be on the December 9th, and I've attached a flyer on the right. And we'll be talking about multi-site studies and surgical care and outcomes in Africa. So without further ado, let me introduce Dr. Monteverde. So Ezekiel is a pediatric intensive care physician who has a degree in statistics for health sciences. He also works as a staff physician in the pediatric intensive care unit from Hospital de Niños in Buenos Aires, and is also currently the scientific director of Fundación Trauma, a non-profit organization that helps hospital healthcare teams to learn from their experiences and to develop improvements and opportunities. He led the team that developed the Trauma Registry from Fundación Trauma, which is currently active in 15 public hospitals from Buenos Aires, with over 40,000 patients included. So over to you, Ezekiel.
Okay, thank you, Megan. First of all, thanks to the organization of the program on global surgery and social change. And now I'm gonna share my screen to start the presentation. Tell me if everything is okay. Is it okay? Are you seeing it?
Yes, we can see your screen.
Well, so as I was telling you, thanks for this invitation that lets us show the work we have been doing for the last 10 years in Buenos Aires province and Buenos Aires city. And this goes with a special recognition for the hospital teams that work every day to improve patient care. Well, trauma systems are the current state of the art for trauma management, and although there is enough information on the benefits of its implementation, including death rate decreases and the improvement of functional outcomes, they are seldom implemented in low and middle income countries. A key component of modern trauma systems are quality improvement programs, which rely on trauma registries as the source of information for their activities, like the morbidity and mortality conferences and the review panels for preventable mortality. So to decrease preventable mortality rates, you need a trauma system. But to have a trauma system, you have to organize the actors, that is to say the hospitals and the emergency systems. And to achieve this organization, you need a categorization process. But to achieve this organization, you need a trauma registry. And for a good trauma registry, you need a high quality clinical record. So in 2010, when Fundación Trauma started its activities, the diagnosis was that to improve the outcomes of trauma care in Argentina, a significant shift in its organization was needed. With the idea of developing a registry-based trauma program, the organization formed a transdisciplinary team made up by physicians, psychologists, and nurses, but also social scientists, data scientists, and communicators. Let me now make a pause and tell you a bit about Argentina and its healthcare system. Argentina is one of the southernmost countries in the world. It has almost 46 million inhabitants, 32% of whom are children and adolescents. and with 16% over 60 years. The country is considered with an upper middle income economy and is divided in 23 provinces and Buenos Aires City, which is a federal district. It has a federal composition, meaning that each province is an independent state and is autonomous in its administration and public health policy. The healthcare system comprises three actors, the most important of which is the one related to the social security that is funded by the registered workers, which roughly accounts for 66% of the population. The public system, totally free of charge for its beneficiaries, which assists 30% of the population, and the private sector, the one composed by health insurance covering the remaining 4%. It should be noted that the initial trauma care, including pre-hospital care, is provided almost exclusively by the public health sector. And to give you a bit of macro context, I may tell you that life expectancy has steadily increased over the last 50 years, and it's now 80 years for women and 73 for men. This trend towards better indicators of public health is also reflected in a sustained decrease in infant mortality. Aside from these indicators, trauma-related mortality has been representing about 6% of total deaths for almost 15 years, with this drop in 2012 that I believe is an inconsistency in the data. From the 2015 to 2019, there was a tendency to lower rates of transport-related deaths, either considered as a percentage of total deaths, that is the blue line with this scale, or as a population rate per 100,000 inhabitants with this green curve. These plots were made using official data from the National Ministry of Health that collects the information from death certificates that are filled at each one of the provinces. When Fundación Trauma started its activities, it was considered that Buenos Aires province would be an ideal scenario to test the project due to many reasons. It is the most populated district of the country with almost 18 million inhabitants, with 11 belonging to the greater Buenos Aires. That is the small area marked by this white line. And the greater Buenos Aires is part of the metropolitan area with Buenos Aires City that has 3 million inhabitants, the space in green. This area has 32% of the overall country population. This province had nation-like average rates of death by violence and below the national average for vehicle collisions and self-harm. Even though we're talking about Buenos Aires now, look at the huge variations between districts, especially for violence. So the initial tasks were to sign an agreement with the province Ministry of Health and with each one of the hospitals that were included in that phase. I may now put another post to tell you that the initial agreement was endorsed in 3 opportunities. Fundación Trauma works to prioritize the trauma problem in the health agenda of the states and to provide them with quality data to guide decision-making. This cannot be done without the support of these ministries, as we believe that the participation of individual hospitals on their own is not enough. This sustained commitment of the Ministry of Health of the province, which passed through 3 administrations, was key to keeping the program running. The election of the hospitals, given that the province had no regionalization for trauma care, was done according to the ministry's criteria for a reference hospital. This phase ended up with a list of 9 hospitals that were progressively included in the program. As we will see later, this list is larger nowadays. One of the problems frequently mentioned in these types of programs is the lack of sustained sponsorship. We believe that one of the strengths of the program was the capability to join the public sector commitment with the funding from the private sector. At that moment, Fundación Trauma's main sponsor was Fundación Pérez Companc, which is still funding the organization's activities. The program included a multi-component intervention strategy, that is the healthcare team training, quality improvement program according to WHO guidelines, Trauma Registry, and Hospital Self-Categorization Process. The program is supported by a central team and a team in each one of the hospitals. The first one is composed by the data manager, a physician with training in injury coding, the implementation coordinator, and the members of the help desk. At each one of the hospitals, there is a team composed by a registrar who is trained by Fundación Trauma, a program manager, that usually is the chief of emergency, ICU, or surgery departments, and a representative of the hospital board. The Trauma Registry is a web-based and locally developed tool that was designed to include hospital-admitted patients, defined as those meeting trauma definition and who remain at the hospital for more than 23 hours. The follow-up period includes all the acute hospitalization phase from admission to discharge. And the registry provides 127 data fields for each case. To our knowledge, this is the first and only trauma registry to be implemented in Argentina. The registry includes information from the pre-hospital, hospital, and post-hospital stages using standardized entry forms. The registry includes standardized coding systems such as ICD-10, Chapter 20 for causes of injury, Chapter 19 for injury description, and it also includes the AIS 2005 for injury coding, along with calculated scores as ISS and ISS, pediatric trauma score, revised trauma score, and TRIS for survival estimation. The original data are obtained from medical records, including nursing and administrative reports. And that is a problem since the vast majority of Argentina's public hospitals still have paper-based records. So we had to make an intermediate form in paper before the entry of the information in the website. The Trauma Registry provides information for multiple levels according to each user profile. The hospital level with information of each one of them, the ministry level reports with aggregated and disaggregated data from each one of the hospitals, and the central level for the Trauma Registry director and data manager. One important aspect that is drawing more attention in the last years is the way registries handle personally identifiable data as a means of preserving sensitive data. In that sense, Argentina law of data protection has been recognized as appropriate by the European Union, and the Trauma Registry was built according to it. These are some excerpts from the Argentinian law, and the registry also runs a dissociation process between personally identifiable data and sensitive data when those data are stored in the database. The results of the implementation of the program can be seen on screen. 8 hospitals were added from the initial phase that I showed you earlier. And as I mentioned, one key part of the program is the healthcare team training, and over 8,000 scholarships have been assigned to professionals. These scholarships are for scientifically supported courses such as HLS, FCCS, ATMR, etc. Nowadays, there are almost 14 cases registered, of whom 33% are kids. These data are from 14 hospitals from Buenos Aires province and 3 from Buenos Aires city. And our next steps will be to deploy the program in Mendoza in November 21st, Tierra del Fuego in February 2022, and Chubut in March 2022 as part of a nationwide implementation. Back to the registry, when we look at cause of injury distribution according to age, we see that the kids had different injury mechanisms, mainly associated with falls and burns, self-harm picking up in adolescence, and transport-related injuries and violence in early adulthood, with falls becoming the main mechanism in the elderly. If we zoom in into childhood, we see that the early years are dominated by falls and burns. These are falls, these are burns. From 14 to 15 by self-harm, and from 16 to 17 by violence and transport-related injuries. In adulthood, there is a continuation of the previous schema, with violence and transport-related injuries in the first years, and falls becoming the main mechanism after 45 years old. In the elderly, falls are clearly the main cause of injury. But one aspect that may be singular of the places I am talking about is the use of motorcycles. Motorcycle-related injuries represent 16% from total trauma and 53% of transport-related injuries. Of note, the prevalence of this mechanism rockets at 13 years old, reaching its highest value at 19 years old when it represents almost 76% from all transport-related injuries. From 15 to 48 years old, this mechanism is responsible for more than 50% of transport-related injuries. The figure shows the rolling average with 5-year periods. This is the blue bold line over the value per each year in the background gray line. Fatality rate was also different between age groups. We can see in this table that while falls dominated the prevalence in children and the elder, the fatality rate was higher for drowning in the first group and burns in the second one. Among adults, transport-related injuries were the most common cause, but drowning and burns had higher fatality rates. The distribution of severity scores shows something that we may see as one of the consequences of the absence of regionalization for trauma care. In this sample of hospitals, the majority of which are devoted to trauma care, 60% of the cases had an ISS lower than 9. This is more evident in children, as we see here on this plot, where almost 80% received this categorization. As we may expect, fatality rates were related to severity of illness, as you can see here on this curve. The registry follows the patient across their hospital stay and can talk about the ways the patient enters or reaches the hospital, either by ambulance or private car, their length of stay, the admission to the intensive care unit, the requirement of blood products, surgery, scans and other procedures, and complications. This data can be analyzed according to each cause of injury. As you can see, the different distributions for transport, assaults, and falls that are the 3 most common causes. With the registry, we can measure and provide the hospitals with contextualized data about their use of critical resources, as blood products, CT scans, mechanical ventilators, and the rate of complications as a whole or specific ones. With these lollipop plots, we can see the use of blood products according to ISS categories, that is minor, moderate, severe, and critical. And we can see here each average. Here in minor, there are transfusions in approximately 2% of the patients, in moderate about 10%, and severe and critical almost 30%. And these plots the average of each one of these hospitals that are plotted in y-axis according to the general average. In relation to the most important or the strongest outcome, that is mortality, the findings in each hospital may be compared to the reference as calculated by the TRIS method. This is a ratio between observed and expected survivors, and this is a simple method that sums up each survivor punctuated as 1 and divides the result by the sum of all survival probabilities calculated by TRIS. This is called the standardized survival ratio that takes into account the severity of injuries, the physiological variables at admission, and the age of patients. Once the ratio is calculated, you may also calculate a confidence interval to incorporate the error related to different sample sizes. The expected result is around 1, and as you can see on the plot, there are hospitals with a below than standard performance, the red ones. There are hospitals with a point estimate below the desired value, but with a confidence interval that contains this value, and there are hospitals that are performing according to the standard. Although these hospitals are good performers, maybe this may be an alert sign. Of course, there were hospitals that performed better than others over different moments of the working period, and we observed big variations and absence of patterns in the most of them. To cast some light on this behavior, we started on 2015 to have meetings with the representatives of each hospital and the province director of hospitals in a working group that received the name of Central Trauma Committee. In each one of these meetings, we discussed some of the common problems seen at the hospitals with the aim of finding solutions that could fit the problems of more than one hospital and to learn from the internal solutions that each one could have built. To foster the merge between the Trauma Registry and the management at each hospital, Fundación Trauma brought to Argentina a team of experts in trauma quality improvement composed by Charlie Mock, Andrés Rubiano, and Felipe Vega to train the first local instructors. So far, we have given 10 courses in 3 years, reaching out for 194 attendants. One of the consequences of having the same team running the Trauma Registry and giving the quality improvement course was to develop in 2019 a specific model inside the registry to flag the cases for revision, define if the case is suitable for an M&M conference, call the attendants, and perform the conference and register the results. Until now, 17 meetings have taken place, 17 deaths have been analyzed in different hospitals, and those are the results. On the right, we can see the registry with a non-reviewed case whose indicator shifts from green to yellow when it is under the revision process. And this is the form that is filled at each M&M conference where you can just mark the situations where you found errors or significant deviations from the standard. And in the last part, there is a free text box to incorporate the suggested corrective actions. To wrap up, we believe that to accurately track patient outcomes, you must implement a trauma registry. That is the one you can, paper-based, electronic, locally developed, or a commercial one. In Argentina, we used to say that the best is the enemy of the good or the possible. So the one you can't will be better than none. Encourage the team because they are the ones that will be in charge of making the system changes. Train the team in each one of these tasks. Train them to improve the quality of clinical records because they are the main source of information for quality improvement programs, but most of all because we owe it to patients. Better clinical records make a safer system and improve patient outcomes. Train them in trauma registry good practices to be more effective in the implementation of corrective actions and in quality improvement to understand the benchmarking techniques and achieve higher goals. Use standardized methods because it is intelligent to learn from others' experience, so we need to share a common language. Program regular meetings with teams from other hospitals because the discussion with other teams that share a common reality can be really helpful in the search for solutions. And last, integrate and involve the local authorities because it is very important for healthcare teams to be recognized in their work towards better care. As Peter Drucker once said, if you can measure it, you can improve it. And this is a fact when talking about trauma care. Thank you.
Thank you very much, Ezequiel, for that amazing talk. So I would ask the audience to hold your questions till the end. And if you could unshare your slides, and then Dr. Soni can put up his slides. So maybe let me introduce Kapil first. So Kapil is currently working as an assistant professor in the critical and intensive care unit at JPN Apex Trauma Center in New Delhi. After graduating from the SN Medical College and Associated Hospitals in Jodhpur in 2003, he did his MD in anesthesiology from the SMS Medical College and Attached Hospitals in Jaipur in 2008. He joined AIIMS in 2008 as a senior resident in the Department of Anesthesiology and is currently a visiting faculty in the University of Michigan, Ann Arbor, as well as an affiliate of the ANZ-ICS-RC, as well as a fellow in designing clinical studies. He's a member of the Standard Trauma Guidelines Group and a part of the steering committee for AITSC, as well as the TITCO consortium. So without further ado, over to you, Dr. Soni.
Thank you, Megan. Can you hear me, and are my slides visible?
Yes, we can hear you and your slides are visible.
Yeah. So thank you, Megan. What I would be doing that is I'll be discussing about trauma registries and outcomes. I have been fortunately associated with trauma registry since almost a decade now in various capacities. First as a co-investigators, and then as in steering committee and designing the trauma registry variables as well. So what I would be discussing, focusing my talk is on Australia-India trauma systems collaboration. I would discuss about the collaborative team. How did we came together? How did we devise this program? And what were the interventions which were carried out? How did we formulate a trauma registry? What were the scientific outputs from the trauma registry? And what were the lessons learned? These are my disclosures. As if now there's no conflict of interest and no off-level association. So the challenge was that in the last decade when we started and I joined the trauma center, we realized that there was a lot of trauma deaths which were happening, and most of deaths, patients were not able to reach to the hospital. The number of road traffic deaths were increasing manifold. They were predicted to increase throughout the decade. Most trauma victims were young males. There was loss of productive life years, and the system was not there. The care for multiply injured, it actually involves a whole system of healthcare. And what we found that though within the hospitals, we were able to provide some care, but the pre-hospital and the post-hospital phases were quite neglected. So this was the big research fund which we got. This was from the partnership of Australia-India Strategic Research Fund. There were two centers. One was the JPN Apex Trauma Center, which is a level 1 trauma center in the country. And the other one was the NTRI, National Trauma Research Institute from Alfred Monarch. Two of my former professors, they joined hands and they decided to do something about the trauma. So this concept actually was formulated from the joint partnership of the India and Australia. The project was about focusing all the phases of trauma care that include the pre-hospital care, the trauma hospital, the rehabilitation as well. And what we decided that to improve all this care, we not only required the training, the capacity building, the trauma system development, but we also required a data registry, trauma registry, because that's the instrument how you would going to measure whether there's an improvement in the trauma care or not. So the aim of the project was to lay the foundation of nationally relevant low-cost trauma systems and for the benefit of injured people in India. This was based on the trauma registry development, manpower training, development of trauma quality improvement programs, and to rigorously evaluate these small or low-cost interventions in a cost-effective way. So these were the 4 interventions. First intervention was pre-hospital notification and structured handover, such as through an app. Second was the trauma extraction and resuscitation, which was focusing more on the resuscitation of critically injured patients who are arriving to the trauma ED. The third was the trauma quality improvement in institutions. It means the care which has been delivered in the hospitals, we realized that that was suboptimal, and we need to improve the quality of care which most hospitals were providing to the trauma care. And after post-trauma, that was a rehabilitation phase, what we decided that will involve expertise for expert consult for the proper rehabilitation of the patients. Now, all these interventions, the trauma registry was a bedrock. All these interventions, we realized that if we don't measure what's happening right now, we can't show the improvement. So the trauma registry was a bedrock. The expected outcomes of all these interventions that we want to test it, the feasibility, effectiveness of the low-cost intervention, to build capacity both in India and Australia, to exchange the knowledge about the practical issues, and to create a network of like-minded clinicians, managers, and researchers in both the countries. So these were the leading partners: the Trauma Center, All India Institute of Medical Sciences, which is a level 1 FX Trauma Center, and the Alfred Monash from the Melbourne Alfred University. Not only these two centers, we got funding from Australian government, Department of Industry, Innovation and Science, and funding from the Department of Science and Technology, India. There were host of other facilities which actually institutions which joined our hands. These were the ambulance societies. These were the Victorian Ambulance Society, the Cash Ambulance Society from New Delhi, and other police and all the social organizations which are involved in both pre-hospital as well as post-hospital care of trauma patients. Those were brought into the collegium. So this is how we started the function. The collaborators were WHO Global Alliance, International Association for Trauma Surgery and Intensive Care, the International Federation for Emergency Medicine, and the NHS from the trauma care in England. We decided to test these interventions in different parts of the country. We selected sites which were representing different geographical areas that included the Delhi, the Mumbai, the Ahmedabad, and the southern Chennai. The data collection tool, the first step was to develop a data collection tool which was feasible and which was practical. That was we called as a minimum data set. Then there was appointment of data collectors, training of data collectors, coding of injuries. Now, when you design a trauma registry, it's important to train the coders and train the personnel who are actually filling this trauma registry form. So we conducted multiple sessions of training of these personnel. So it's important to have a designated independent data collectors for making it an efficient trauma registry. So the bedrock was as a trauma registry, there was development, because before this the 4 interventions, there was no trauma registry in these hospitals. So what are the trauma registries? These are basically a key component of trauma systems. These are basically nothing else but the databases that actually capture different phases of trauma care that include pre-hospital, hospital, post-hospital. They allow benchmarking of trauma systems, and they inform trauma quality improvement programs. At that time, we realized that most developed countries, they were having trauma registries. However, from India, there was only one trauma registry which was functioning. And we thought that we need to be more, because it's quite a populous country and a lot of trauma deaths happen in the country. The publications were increasing. There were increasing registries from developing countries as well. So the method of devising a trauma registry was, we started with some pre-pilot phase and a post-pilot phase. In the pre-pilot phase, we had multiple meetings of key stakeholders. We identified the relevant variables which were feasible and plausible. We developed a data dictionary. There was training of the personnel. And then in post-pilot, we realized that not all variables which were able to capture. We revised our variable selection. There was a revision of dictionary, and then there was retraining. So this was a pilot phase. There were 2 objectives. One was on the long-term future. That means to develop a minimum data set which is feasible, useful, and consistent. On the other hand, we also wanted to devise a data set which can deliver additional information relevant to all the 4 interventions which are planning for this project. On the other hand, WHO at that time was actually developing a global minimum data set, and that helped us a lot. We borrowed a lot of variables from the WHO data set so that the capture remains consistent. The WHO data set is basically a utility, very useful data set. It provides a lot of functionality. The feasibility is there. So the principles were both. When devising a trauma registry should be able to capture and with good data quality. Now the most important part was that we wanted to keep it simple, because we don't want to capture each processes in details, because if we target too much of details, we'll lose out on the quality of data. We realized that we should be able to capture the surrogate variables which are representative of of phases and which are quite relevant. So these were the initial variables which we identified. They were demographic variables, event variables, processes variables, severity variables, and outcome variables. There was division of data dictionary, which was harmonized with WHO injury surveillance guidelines and other international bodies. Plus, this data set was also capturing all these interventions which were planned and were conducted. So the trauma registry was doing that all. The result of pre-piloting trauma registry is that initially we targeted almost 130 variables, but we realized that we are not able to capture all those variables. And in the post-pilot, we restricted ourselves to only 80 variables. So that's how almost 50 variables were cut off from the trauma registry. So these were the post-pilot data sets. There were almost 82 data sets: arrival data, injury event data, demographic data, hospital data, which is affecting the both physiological and anatomical results. The coding that included various regions of the body, ICD coding. So a multi-center trauma registry was devised. It demonstrated feasibility, and it also demonstrated usefulness for EITC interventions. It proved useful for quality improvement activities and also with the Uniform Global Initiative at the outset. However, remember that when you devise a trauma registry, it has to be very context specific. It's quite an iterative process. There are a lot of data elements, data coding. You're always tempted to create, include lot many information, but sometimes you have to bargain between what are feasible and what are not. So need to pay close attention to data elements, data coding, data quality, data utilization, and sustainability. So these were the data-wise elements which were recorded in the database. Fortunately, almost 99% database was recorded in 3 years of conduct of the trial. What major findings were that majority of patients were around young, 30 to 40 years. 61% of injuries were road traffic injuries. Almost 30% were falls. 1 in 4 patients were motorbike injuries. 4% of patients were injured in railway accidents. 48% patients had a head injury, and 50% of patients were all polytrauma patients. We realized that the survival rate was around 88%, whereas non-survival was around 12.4%. We also looked at various survival across the proportion of blood pressures, the mechanism of injury around Glasgow Coma scale and injury severity scale, and we found that there was quite a difference between these survival curves. This registry actually enabled us to come out with many publications. One was in pre-hospital notification, the other one was about outcomes, the analysis of mortality. Then there was on arrival vital signs. Then there was missingness data, the checklist of trauma quality improvement, and other parameters. So this publications are still in process. So this was the publication which I authored as a first author, where we looked at whether there was a difference between the trauma mortality in patients arriving during hours and after hours. We hypothesized that because the resources are less in after hours, the patients who are arriving after hours should have a higher mortality compared to the patients arriving at office hours. The study was conducted it's a registry study which we got data from the 4 hospitals. These are participating centers. The participants were all these patients admitted in the hospital with potentially life-threatening injuries, and the patients who were dead on arrival were excluded. There was a standard definition of office hours and after hours, which we defined based on our own context. The EITC registry was again used for all these analysis. What we found, the demographic data, the process of pair within the first 48 hours, the endpoints were selected, and we found the mortality was not different. In fact, office hours mortality was around 11.6%, whereas after hours mortality was around 12.1%. The baseline characteristics was quite comparable in both the groups. So there was not major difference. What we found that when the process of care was also not much different. When we adjusted our outcome on the confounders, there was not major difference between the mortality. However, there were secondary outcomes which were a little different. So the confounders which we adjusted were the age, gender, presence of shock, severity of illness, and referral status. So we concluded that whether the patient arrives during the hours or after hours, there is no difference. Its strength is that it's a multi-center cohort coming from the 4 large public hospitals. The Trauma Registries is providing the source of data. There's a large variation which is prevalent in the resources. However, this multi-center data could mask the intra-hospital variation. Though we did do some sort of generalized linear mixed modeling to neutralize the intra-hospital variation. So the conclusion was the mortality was not different between these 2 hours group. So the learning is that the trauma registry is basically an integral part of robust trauma system. When you are developing any trauma systems, the trauma registry remains the source of data. You can measure the outcomes, you can measure your interventions, and actually see how much changes are brought about through a trauma registry. It forms a bedrock in which most trauma interventions are planned. It relies on data quality. When you are devising a trauma registry, it's important to maintain the data quality. In our case, the data quality were maintained by the Australians. They were quite particular about the errors, the missing values, and all. So this quality was maintained. Importantly, feasibility and the plausibility of data is important when you're devising a trauma registry, because it should actually represent multiple aspects of the system. So it does provide a lot of answers. Fortunately, at that time, the Prime Minister of Australia did visit our center, and we were happy to show our project with him. Thank you. Thank you for patient listening.
Thank you, Dr. Soni. That was an incredible talk. And thank you, the both of you, for speaking to us today and sharing your experience with trauma registries. I just wanted to open the floor to questions. But before that, I just wanted to share my screen again. It's just, let me just try that. Hang on. Okay, so at the start, we asked everyone to fill in a poll, and it looks like everyone's joining in from all over the world, from New Zealand to America, South America, Europe, Africa. I just wanted to thank everyone in the audience for tuning in for this research seminar. And so now we will move on to discussion. So if you could raise your hand and before you ask your questions, that would be great.
I have my hand up, Megan. Can I go first?
Oh, yes. Yeah, I can't actually see the participant.
Yeah. Oh, really? Well, first, let me just say that thanks to Ezekiel and gosh, I can't, Kapil. I mean, these were just fantastic talks. So I'm Key Park. I'm the director of policy and advocacy for the program in global surgery, and not taking away anything with the work that you've done as far as the content and the findings and the impact you're having in country. I want to just sort of take ourselves to a higher level and talk about how do we democratize this trauma registry across the board, right? Looks like both countries have, taken on their own construct of developing their trauma registry. And is there a way to, is there a path? Is there one right now of a single trauma registry that we can all use off the rack? If not, how do we get there?
May I answer you?
Yes, please go ahead.
Okay. Well, the idea we have at the organization is that we need to the commitment of the public sector in the way that they are the administrators of public hospitals, that here in Argentina are the most important actors in the early phases of the trauma patients, trauma patient assistance. So the way we've been working with the province of Buenos Aires and Buenos Aires City was to engage the local authorities and to incorporate the funding of the private institutions. And that is a way we've been working for the last 10 years. As I showed in the presentation, we are expanding the program to reach 3 more provinces, one in the last month of this year and the other 2 on the first semester of the first half of 2022. And we are having the same idea to engage the local authorities, public authorities that are responsible for pre-hospital treatment and also the first response at the first attention at the public hospitals. And the other part of the question that was related to if we need to use all of us the same registry. I don't know if it is necessary. We need to share a common language. We need to share the common standards, and when we agreed upon which standards should be used, I think that everyone could use the registry they want, but according to those standards, to be able to for the systems to interoperate, or not to interoperate, but only to dialogue in the same language.
Thank you very much for answering that. I also see another question. It says it's from Vignesh. Vignesh, do you want to unmute yourself and then ask your question?
Yes, hello, can you hear me?
Yes, I can hear you.
Hi, thank you so much for the amazing presentation. I was wondering, are there any differences on data collection and inputting into the registry between hospitals based on staffing availability and based on resource availability and things like that? And how are these differences in data collection and data management addressed?
Maybe Kapil, you can answer that.
Yeah, so during the trauma registry, we realized that we will need additional manpower to collect all this data. The current staffing which most hospitals have in India, they are heavily overworked, and it's difficult to gather a quality data with completeness if we employ the current personnel. So what we did in our own trauma registry, we got 2 data collectors at each site, which was there between 9 to 7, and then the rest of data was extracted from the records. Again, it becomes a matter of funding. How much fund you have for running a trauma registry? It's an expensive affair. Running a trauma registry is an expensive affair because you would need to employ data collectors. You will need to employ people who are consistent with all these data dictionary, and they are able to extract the same information from different centers. Definitely, different centers will have different contacts. They would have different type of patients coming to them, but that's how you need to capture. Single center hospitals will never work. You need to capture at least different geographical areas. There would be some variation that you expect when you capture different data.
Okay.
Thank you. And just to follow up on that, when you're setting up a national registry, in the first presentation, there was sort of a structure on local data collectors, and then you've got a central team. So as you're progressing up and expanding on the registry, how are the central teams managed? So are they based on geography, or as you progress up, would there be a central team at a national level? So how is the sort of governance managed for as this network grows and the registry grows?
Well, the situation here will be to deploy the program in each one of the provinces. train the teams at each one of the hospitals that are in those provinces, and the registry will still be managed by a central team, not depending on the province we are working with, but with just a central team for the whole country. At least until now, there was no problem with that, and the way we are thinking of progressing the implementation, we think that we will not have any problems. We developed a totally online training program for the institutions, for the teams working at the institutions, and we have a help desk in the 9 to 5 hour, so that they can evacuate the problems during this time, and also we can be in contact by WhatsApp or other means. That is the way we've been working, and until now, at least, it has worked well.
Thank you so much.
Okay, thank you both. I also see another question from Livia. Livia, would you like to unmute yourself and ask your question?
Sure. Hello, and it's great to see Ezequiel Monteverde and all the team at Fundación Trauma. I spent some time with
Hi,
them
Livia.
a couple of years ago, so it's wonderful to see you here. I was wondering about, this is more of an anthropological question, I guess. I'm an anthropologist. Who was the hardest actor to get sort of on board with the program, right? Because it's an additional task, an additional responsibility that you are giving to certain members, right, in the team in certain hospitals. So what is the sell? What is the pitch that you give? And also, I know you had talked about potentially having a post-hospital sort of program and following patients. So I was just wondering how that was going, but great to see you and great work.
Thank you. I think that the most important problem, the most important hurdle was to engage the local authorities. But when they were engaged with the program, they understood it was a very solid partnership we constructed all across these years. I shown that in the province of Buenos Aires, this program went through 3 administrations. So it is very important for us because in Argentina, it's very common that the local health policies are not sustained between governments that do not share a common background. And so to us, this is very important. This has it is more important than if it had happened in other places. But inside the hospitals, I think we shifted between different ways of implementing the program. And I think that the last one was the more solid one, because I don't know, because we reached at that way of implementing the program just simply because we failed with the previous ones. But it is now very solid, and we have, I think, one of the characteristics that may be linked to this. To this sustained partnership was that they can talk to us each day they have a problem, or we talk to us even if they do not have a problem, just to see how are they doing with particular problems. Like during 2020 with the COVID pandemic was one of those situations in which a lot of people had to work from their homes, or even weren't allowed to be at the hospital, but also couldn't work from their homes because there was no system, no communication system to sustain that. And I think that the relationship we built with the healthcare teams at each one of the hospitals, that's a human communication was key to support the program this year. And as you told, the post-hospital stage is programmed to be started somewhere in these years, but we haven't been able to deploy it yet. We have the registry, we have all the processes on paper, but we haven't been able to deploy it on the field. So if I may tell you something about this, we have like a spin-off of Trauma Registry that is a hip fracture registry. And we are building, I think, a more solid program to be for the follow-up of these patients, like more solid in terms of our relationship with the hospitals. And I think we will be like more able to tell you something about post-hospital follow-up when we deploy in the last month of this year, or the early ones from next, the hip fracture registry.
Thank you. There's also a pandemic, so post-hospital stuff is hard.
Yes.
Okay, thank you, Ezekiel. Over to you, Kapil. I see your hand raised.
So just to answer the question, for India, the difficult part was collaborating with agencies which were outside the hospital. Within the hospital, we realized that it's easy to convince colleagues from different backgrounds, from physicians, AD physicians, surgeons, and all. However, when we needed collaboration from agencies who were actually responsible for bringing the patient to hospital or a post-hospital rehabilitation, those were the major stumbling blocks which we faced. Initially, there was no coordination, and most agencies they worked in silos, and the major problem is the coordination between different agencies and the hospital. We tried to bridge this gap with the development of apps and all. However, we were not that successful. We need to still work on this coordination a lot, and these are the areas which need future work.
Thank you very much, Kapil. I see Rashi, you have your hand up. Over to you.
Thanks, Megan. And thanks, Dr. Monteverde and Dr. Soni, for really great conversation. I had some questions that we discussed both of these papers in our journal club on Tuesday. And then one of the things that we were talking about and didn't really have a chance to dive into much then, and I was wondering if you could give your thoughts, is a little bit about the Irb approval process and the ethics permissions behind creating a trauma registry or a data registry like this. Did you feel like or did you face any specific hurdles in creating a large scale registry of this type in terms of getting permissions? And then as a follow-up to that, and a little bit going off of what you've said already, have you run into any issues or things that you did not anticipate about issues of data ownership and understanding, in such a collaborative environment like this, who has ownership over the data? Has there been any issues with that? Any kind of thoughts on that? Thank you again for really, really thought-provoking talks.
Okay, Kapil, maybe you can start.
Yeah. So Rashi, as far as Irb and ethics were considered, because we wanted to run these interventions in 4 different centers of the country, we needed a network, we needed a like-minded people. We approached other hospitals as well. However, they were not that willing to join us. Fortunately, because we were leading Apex Trauma Center, we are the premier institute of the country, we were still able to got some people from other parts, other hospitals. So IRB was not an issue. We did got approval, ethics approval, and so that was quite a smooth process. Data authorship and data ownership is still what we told that initially all the hospitals, they were free to use their own data. But when they wanted to use the data from Trauma Registry as a whole, they needed to take a permission from the Central Steering Committee. And that's all the conditions which we set at the beginning of these 4 interventions when we were preparing or we were drafting the Trauma Registry elements. So these all conditions were set before we began the process. And these were made very clear. The terms of authorship, the terms of ownership of the data were very much clear before these interventions could actually begin in different centers. So these were all thoughts which we knew that this will become a problem if we do later on. We realized quite early, and so we made it very clear before beginning of the project what are the terms and conditions, and those were all acceptable to most stakeholders. Over.
Yes, I think that what Dr. Kapil has said applies to the same way to our registry, because we have like this same organization. The hospital is free to use all their data. If they want a specific data set, they should ask for it, but with there is no problem to give them that. They have automatic reports running on their screens each time a new case is closed. And when they want to make research using all the database information, they have also to ask for an authorization of the Central Committee. With the IRBs, given that this is not a registry for an investigation, this is a registry whose main goal is to improve the quality of care, and because the registry was built according to the aspects of the Argentinian law of the data protection, we had no problem with that. When there are research teams at one or more hospitals that want to make a research using the data from the Trauma Registry, they need to ask for an authorization for the Central Committee, but they also need to present the research protocol at the IRB and also at the Research Ethics Committee at their hospitals. And that is a way that the system works. We had no problems with data ownership in these years, and I think if nothing changes, we won't have in the future, because everything was done according to what the regulations say.
Thank you very much, the both of you, for answering that. I think I saw a raised hand from Callum as well. Callum, do you want to go ahead?
Yeah, hi. Thank you both. Really interesting talks and very insightful. Something else that we had discussed at our journal club earlier on in the week was around kind of data collection and data capture and the issue of missing data. And we'd kind of spoken about kind of methods of data collection in your registry, Dr. Sunny. You had specifically trained data collectors, but we also discussed about the medical team kind of capturing data and how best to streamline that. And we talked about electronic records and the likes. We just wondered whether you had any kind of thoughts or insights about how best to streamline that, and I guess especially in light of maybe expanding the use of data registries into kind of rural centres where maybe you don't have the same kind of capacity in terms of medical personnel or administrative personnel? Thank you.
Thank you, Dr. Kalam. So what we did in our registry is we employed data collectors which were actually trained. We realized that if we rely on medical personnel or nursing staff or doctors to feed us the data, most of the time the quality of data actually suffers a lot. And that's a problem because the hospitals are quite old when they with lot many patients, and the resources are quite scarce. If we wanted to capture with certain quality, we needed external data collectors, and that we employed at a different sites. The problem with that is that it includes more expenses. The data collectors were present only during prescribed hours. That means they were available from 9 to 7, so they were recording the observations, what they were able to see. However, if the patients came in the night, most observations were extracted from the medical records, and we acknowledge that in our own in the research papers as well. So that was the limitations of the registry. So how did we got the data? Because most data collectors, they were not that frequent using the electronic data sheets. We don't have that much of electronic data available in most hospitals, or a EMR system or like an Epic system available in most hospitals. They still rely on paper-based information. We designed specific forms. The data collectors were supposed to fill specific information on paper collection, and those were then scanned and sent to the central team from who are monitoring the quality of data. So that's how it was done. As far as rural part of the country is concerned, we still rely on the paper methods. The electronic data collection is not that developed. It's still by using paper and the hand, and all these informations are gathered. So it still needs a lot of it would require a lot of funding and investment for electronic records to come up, which will take a lot of time. So I still see a paper sort of on a hybrid basis, where we can employ technology, we'll employ. If we not, then the paper collection tool is still the go-to tool for trauma registry as if now. Hope that answers your query.
Yes, thank you. Yeah.
One of the problems we had, I think that is a common problem of trauma registries, is the missing data, especially of our physiological variables at admission. I remember that in that paper by Pape et al. That where they presented the Berlin consensus for not the Berlin, the Berlin consensus for polytrauma definition in 2015, I believe. They were talking about 30% of missing data in physiological variables at admission. That was similar to the one of the paper from the Tokyo Trauma Registry. And that is a very high proportion of missing data. We have at the registry more or less the same proportion, about 30%. That is a problem for benchmarking techniques because TRIS method is based on the RTS that requires the blood pressure, the Glasgow Coma Scale, and the respiratory rate measured at admission. So the way we handled with this problem was to develop an algorithm to walk over the problem of missing data and being able to use the whole database. And for benchmarking techniques, we use this algorithm in the cases we can't use the TRIS method. The results from these algorithms were comparable to the results given by TRIS method. And so that is the way we internally can flag those cases that need hospital revision in morbidity and mortality conference, even without the data from the TRIS method.
Okay, thank you both for answering the question. I see Bethany, you have your hand raised. Would you like to speak?
Yeah, thank you, Megan. Thank you, Dr. Soni and Dr. Monteverde. Great talks, and really have learned a lot. I think there's a lot, even outside of trauma registries, that we can extrapolate from this conversation. So building off the last few questions, and Dr. Soni, I think something that you mentioned in your talk about less is more. And I think the challenge of people wanting to put everything into these systems, but capturing too much data can really be at the detriment of the systems. Curious how within your different programs you negotiate what's included in the registries. I'm sure a lot of people are asking for a lot of things. So how do those conversations play out? And then on the flip side, if you personally could add one other data element to your registries, what would you add?
Yeah. So definitely the feasibility actually it varies from context to context, and how much it's a discussion when you design the trauma registry. As we clearly showed, initially we piloted almost 130 elements, and we realized that post-piloting there were only 80 elements which we were able to capture with quite certainty and with quite good quality. Whereas we have to shut off rest 50 elements. So it's again a task. It's sort of you need to pilot whatever you devise a registry, because it will never be a perfect registry. Certain things you will need to let go. Certain things you need to bargain. Okay, these are the important elements and these are not. First thing which we really miss is basically the complications which were happening during the stay within the hospital. And the reason being, most physicians, treating physicians, they were not comfortable discussing the complications or mentioning the complications in the data in the medical records, and because of fear of litigations and all. So that element we still feel we lack capturing the complications, specifically the infections and the other complications, because they were not that clearly stated in the medical records, nor the data collectors were equipped were capable to identify those. So these, if we are able to capture complications, we still feel that we will be able to know why the patients are developing and what complications they are developing during the hospital stay. Post hospital also, the quality of life and the follow-up is a difficult task, and it needs again a lot of investment. So what happens to the patient after 1 year? So that was all information also not captured in the trauma registry. So that are the two areas which we need to improve when we are considering trauma registry for our own context.
Yes, I think that the way we managed the different levels, or like the data fields that needed to be incorporated into the registry, or the ones that could be negotiated, we ran from a very basic registry towards the full one, and we described or just managed 4 levels of registry. And when we make an agreement with each hospital, we talk to them and ask them how confident they are to fulfill the fields that are in each one of the 4 modules. So that is a way that we run from a level with, I think there are 53 or 55 fields to 127. And we monitor the missing data longitudinally. So we ask them if we can see that there is a specific data field that is continuously missing. We ask them if what is happening to that, and see if something in their process of registry can be changed. I think that there's the most feasible way that we found to manage with that, and also name that the basic model, the basic model contains what the GACI, the Global Alliance for the Care of the Injured, considers as the minimum data set. And when for Bethany's question about what will be the data field that I would add to the Fundación Trauma's registry, I think that that field is not related to the registry itself, but it is related to a problem of process. And I would like to see what happens with trauma patients that are discharged from the hospital at 6 months post-discharge.
Thank you both for answering that question. Are there any questions from the audience? Okay, Key, I see your hand raised.
I get the double dip today. Yippee. Hey, a quick question. The WHO International Registry for Trauma and Emergency Care, I'm sure you're both aware of it. What is your relationship with this registry, and how much involvement do you think the WHO should have in developing a universal trauma and emergency registry?
Well, to talk about Fundación Trauma, we have no relationship with them, and the way I think about it is that the WHO or any organization that wants to set the standard for either intervention is I think that their role would be to set the standards, to set the definitions as they did with the Global Alliance. But the way the people enter their data in each part of the world should be done according to each one's possibilities. Because maybe that when at one hospital, they care for a specific part of trauma patients or a specific issue on trauma patients, then another does not pay attention to or pays less attention to that point. So I think that the registries must be built according to each community's interests, but to share a simplified or minimum common data set that could be shared between all the members, so that we can build better information for that specific core set.
Thank you very much. Do you, Kapil, do you have anything to add?
Yeah. So yes, so when we were designing our own trauma registry, we did look at the WHO minimum data sets, and definitely we wanted to include all those elements which were mentioned in that. Additionally, we wanted to include elements which were representative or which were capturing our own interventions. So the WHO did form a basis of selecting the elements and the variables. Apart from that, there was no direct transfer of data to the WHO, but definitely that does provide a common minimum data set. Again, that needs to be modified and modulated based on the local context and the availability of resources. Being a large country and the heterogeneous resources in India, the compliance to all these variables may not be there. So that requires a modification in the registry.
Okay, thank you both for answering that question. Let's see. Well, I have a question. I've been working on the wound registry in Singapore, and it's very hard to set up a registry and even harder to sustain it. And because the both of you have, such extensive experience with the trauma registries, I was just wondering if you have any advice on how to keep the registries going.
So the trauma registry was our trauma registry was restricted to the period which we were getting the funding. Since last year we needed to stop it because of a COVID pandemic, and the resources were diverted towards managing the COVID pandemic. So that has taken a toll. We have been quite inconsistent from the last couple of years. Before that, we have in-house trauma registry, which is actually still capturing the data elements which we designed for the project. So again, it's all come back to the resources. As if now, most of the resources have been diverted. The funding has been diverted for the COVID, so that has impacted a lot.
Yes, I think I made a comment on that after one of the questions, and I think that to keep the program running and to keep the teams at the hospitals with enthusiasm about the work they do, there is no single instruction or opinion. The way we've been working with them is to build like a friendly relationship, to help them in their work and to give them support. And I think I have no other idea of how this works, but it works because I think that people need to talk. People have a lot of doubts while doing their job, and so to feel more like backed up or supported. It's I think a good recommendation will be that they that they can build a project in which they can be supported by a person who they can talk to by phone.
Thank you both for answering my question. Are there any more questions from the audience? Okay, I don't see any hands raised. Okay, and it's quickly approaching 10:30. So I think I'm gonna wrap it up. I just wanted to thank both the speakers again for sharing your experience and sharing your experience with the trauma registries. I would like to ask the audience to fill up a survey to give us feedback on how we can run the seminar better next time. I will post, I think Beth has already posted the link in the chat. If you could, spare a few minutes filling up the form, that would be fantastic, and we would really appreciate it. Yep, I think that's us for now. If you want to see the video of the seminar, you can hop on to our website at www.pgssc.org/research seminar. This should be up in about 1 to 2 weeks time. And the Facebook Live is going on as well. So thanks for everyone who have joined us on Facebook Live. And I'm gonna stop share now. And okay, all right. Thank you so much. I'm gonna end the seminar. Any last words from Ezekiel or Kapil?
Thank you all. Thank you.
Okay.
Okay, thank you, Megan. Thank you, Bethany. Thank you. Thanks everybody for keeping up to this time.
Thank you all. I'm going to go ahead and close out the meeting, but we look forward to seeing you next time.